Good morning. My name is Ellen Morrow, and I'm going to discuss the role of manometry in anti-reflux surgery. I have no relevant financial disclosures, but I have been to the Ethicon course regarding the LINX device in 2019. So the question for this presentation, I think, is do we really need to do manometry before we wrap? My answer for you today is yes, you do. So I hope to convince you of that in the next few minutes. The reasons why I think this is important, one is that I think you need to identify major and minor motility disorders before you alter the patient's anatomy with your anti-reflux surgery. There are a few reasons why I believe this is important. One of them is that you can better counsel patients about the causes of their GERD. So for example, if you do find that a patient has ineffective motility by doing a preoperative manometry, you can counsel them that this is probably part of the reason why they're experiencing severe GERD, and that that's not necessarily something that you anticipate will improve with surgery. Another important reason is that although major motility disorders such as achalasia should be rare, it is important to confirm that the patient's symptoms are actually related to GERD. We do know that patients with achalasia are often misdiagnosed as having GERD for years prior to their achalasia diagnosis. So this is an opportunity to identify major motility disorders that might otherwise be missed. Another reason to always do manometry is that it will allow you to troubleshoot your patient's symptoms if they do have any post-operatively with better knowledge of the patient. So if your patient does have post-operative dysphagia, for example, and you got a preoperative manometry, you're going to feel more comfortable dealing with that side effect of surgery armed with that knowledge of their preoperative esophageal physiology. So what does SAGES say about this? Well, the SAGES guidelines for anti-reflux surgery are from 2010, so they're probably due for an update soon. But what SAGES says is that esophageal manometry is frequently performed before surgery and advocated by many experts in order to identify conditions that might contraindicate fundoplication, such as achalasia, or modify the type of fundoplication according to a tailored approach based on esophageal motility. Nevertheless, there's no support in the literature for mandatory preoperative manometry, and there are numerous studies refuting the need for a tailored approach to fundoplication. So, kind of a mixed bag. Additionally, in those guidelines for anti-reflux surgery under esophageal function, it's stated that a normal LES pressure on manometry has not been shown to be associated with increased rates of postoperative dysphagia. And that patients with non-specific spastic esophageal motor disorders such as nutcracker esophagus or hypertensive LES have been reported to be at increased risk for postoperative heartburn, regurgitation, and dysphagia. So again, that's where preoperative manometry could help you potentially counsel your patient about expected postoperative results. So why would you not do manometry? Well, this is a very uncomfortable test. So shown here is the manometry catheter. And I do hear from my patients that this is, usually the most unpleasant test that they've ever undergone. So that is one thing that I consider when I'm thinking about ordering a manometry. Some patients who have very, very large paraesophageal hernia, which I don't really think is the subject of this session, but if you do have a patient with a large paraesophageal hernia, for example, with gastric volvulus or totally intrathoracic stomach, it is going to be technically challenging to get that manometry and somewhat more challenging to interpret it as well. So those are considerations, and I will admit that sometimes in patients with large paraesophageal hernias, especially if they're experiencing weight loss or other relatively urgent symptoms, I sometimes will defer manometry in those cases. I'm fortunate to practice in a large academic center, but not everyone has access to manometry as readily as I do. And so I know that availability of manometry or patient travel time can be concerns for certain surgeons and patients. I can't really comment more on that, but I know that that is a very legitimate consideration. Now, some people have argued that they don't need to do manometry because they always do a partial wrap. This is a reason that you wouldn't need manometry to consider tailoring of a wrap. So maybe you're not quite as concerned if your patient has ineffective motility, but I still think it's important to know what the patient's physiology is before you operate, again, so you can better counsel that patient and rule out motility disorders that might actually change your management. But even if it won't change your management, I still think it's valuable information for you and the patient to have. And then actually recently I've heard the argument that some esophagram protocols may be just as helpful for operative planning. I don't believe that this is true. So here you can see the Chicago classification, and we know that with high resolution manometry and interpretation based on the Chicago classification, we're identifying more motility disorders and diagnoses than we used to. And so I do not believe that there's an esophagram protocol that can give you as much information as a high resolution manometry study. However, if you are practicing in a location where you have a standardized protocol and radiologists are very comfortable with esophagams, it may be a good screening tool. It will not provide you as much information as a manometry study. And additionally, I think a lot of radiologists these days, and I'm sure this is variable from center to center, but a lot of radiologists really aren't that comfortable with fluoroscopy studies anymore. And so, you know, I think this is another reason why manometry is an important tool for preoperative evaluation. So let's say you do your high resolution manometry and then you're faced with some management dilemmas. So what do I do when I have a patient who has ineffective motility as shown here? Does that mean that they're not a candidate for anti-reflux surgery? Typically not. In my practice, a patient with ineffective motility is someone who I would offer a partial fundoplication, although honestly I do mostly partial fundoplications regardless. What about spastic disorders? Well, I think this is something where you do have to be careful, and you really want to be careful about counseling your patient and assessing their symptoms well. And I really think that a lot of your management choices depend on what symptoms the patient is primarily presenting with. So if you have a patient who does have a spastic disorder that's identified on their manometry preoperatively, but their symptoms are primarily reflux symptoms, not dysphagia or chest pain, I would still feel comfortable proceeding with, again, probably a partial fundoplication in that case, as spastic disorders can sometimes be related to reflux and sometimes improve after fundoplication, but you do have to be careful there. And if you're not comfortable, these are great cases for a multidisciplinary discussion, potentially with your GI colleagues, or you can always consider referral if that seems like a case that requires a second opinion. EGJ outflow obstruction can be classified potentially as one of those spastic disorders as well, and that can be a challenge. Again, if the patient is presenting primarily with reflux symptoms and not with dysphagia, that's still someone who I would offer most likely a partial fundoplication. But if that patient does have a significant amount of dysphagia, then they may need a different treatment plan, potentially a trial of a Botox injection with consideration of myotomy later on. What about the Lynx device? So a Lynx device is part of the anti-reflux surgery menu of options these days. And the folks who do Lynx will tell you that preoperative manometry is probably even more critical in this setting, given that the Lynx device does have higher rates of at least temporary dysphagia postoperatively. There are some people who are putting in Lynx devices with a detailed esophagram protocol only, but I would advise high resolution manometry before consideration of a Lynx, especially given that dysphagia is one of the primary reasons for explantation. In conclusion, manometry is not considered mandatory before anti-reflux surgery by all surgeons. However, it is advocated by many experts, including me. I would say that it can help you counsel patients preoperatively. It can also help you evaluate any symptoms postoperatively. And it can help you potentially even avoid the wrong treatment decision in certain cases. So if you have access to manometry, please use it. Thank you.